So now we're going to move on to somatic disorders. And y'all have probably heard of hypochondria. Hypochondria is the old term, but the scientific term for that today is somatic syndrome disorder. This is when a person manifests a physical ailment, but there is no physical cause. Instead, there's a psychological cause for their physical ailment. And usually that's going to be tied back to stress or trauma. Like y'all may have seen the Sherlock Holmes BBC version with Benedict Cumberbatch. When John Watson came back from the war, he walked with a limp. It wasn't because he got shot in his leg, it's because of the stress and the depression that he was under. So psychological problems manifesting as a physical problem. Now, technically, there's two types of somatoform disorders. And the first one is called a conversion disorder. This is when you can have extreme, severe physical problems that have no physical cause. They're from stress or anxiety or a psychological source. So a person with conversion disorder could develop paralysis, numbness, or even blindness. And there's no medical reason for that occurring. Can you imagine just like you're stressed one day and then you go blind? You'd be like, what's happening? So lots of anxiety, very, very difficult. And so they report physical problems that are literally there. They're not making them up. It is there, but there's no physical cause. It's in the psychological cause. The other type of somatoform disorder is hypochondria. This is where a person has a high fear or anxiety about developing a serious illness, or that they're convinced that they have it already. So like if they have a headache and then they go on WebMD, y'all know what WebMD is going to tell you. WebMD is going to tell you you're going to die in 7 days. It's going to be like, you have a tumor. Or like, I'll go on WebMD and be like, I have a stomach ache. And they're like, yeah, it sounds like you have prostate cancer. And I'm like, I'm pretty sure I don't, but okay, WebMD. So they'll take every little minor physical symptom and believe that it's more serious than it actually is. This doesn't mean they're faking it. They believe that they're ill. They actually believe that they're ill. It's just that it's blown out of proportion. It's a fixation on minor symptoms that builds up anxiety in them until they believe, this is it, I'm going to die. Another part of somatic disorders is illness anxiety disorder. This is not necessarily meaning that you have the illness or you believe that you have the illness, but rather you're obsessed with getting it. So you're trying to avoid getting the disease. Now, there are two types of people with illness anxiety disorder. There's the care-seeking type, which is constantly going to the doctor and saying, hey, I've had this symptom. I need you to test for this. I need you to check for that. Or care-avoidant type, where they believe that they could be sick, but they refuse to seek medical help. So this can manifest in different ways. So what causes somatic symptoms? Well, if we look at the psychoanalytic approach, the Freudian approach, of course, this ties to your unconscious. You have repressed emotions that you are not looking into. Now, these are unconscious. This is different from suppression. Suppression is when you push it away on purpose. Repression is when you push it away without even knowing it. So you need to get those repressed emotions out, or else they're going to manifest as physical symptoms, physical illnesses. The behavioral approach says that people with somatic symptom disorders get rewarded for their attention-seeking behavior. They get attention from doctors or nurses or family or peers, or they get medication that encourages their behavior of going to the doctor over and over again. Although they must have good health insurance, because I try to avoid the doctor at all times. I once took an Uber to the ER. I wasn't paying for an ambulance. Kidding me? On a teacher's salary in this economy? The sociocognitive perspective is when people pay too much attention to their health, and so they're more likely to realize that something's going on. But not so much that it's actually a serious thing. If you go into a CT scan, the doctors are going to find something. There's always going to be something wrong going on, not necessarily causing problems, but maybe you have a kidney stone or something, just something going on that would show up on a CT scan. But if these patients are so in tune to their health that they notice even the tiniest changes, like a slightest change in a mole on their shoulder or a blemish, or they feel an ache in their thigh, they're immediately going to assume the worst. They're immediately going to assume something is wrong. And this can lead to confirmation bias. Let's say that that person notices a spot on their elbow and they go to WebMD and they Google spot on elbow. Well, they may ignore normal things like ingrown hair or scab or burn or something, and they may go directly to melanoma. And they're going to be like, I knew it. I knew I had cancer. This spot proves it. The internet proves it. This is confirmation bias. They ignore all other information except the information that confirms what they already believe, which is that they are sick. Now, factitious disorders are different from somatic disorders. Remember that factitious disorders are a person deliberately making themselves sick or faking an illness. That's different from somatic. In a somatic disorder, a person thinks they are legitimately ill. They just over-focus on the symptoms, or they're more sensitive to the symptoms. They're afraid that they have a debilitating disease and that they can't find a way to prove it, but they legitimately think that they're ill. Or they have symptoms, but it's psychological symptoms manifesting as a physical disease rather than a physical disease that manifests from a physical cause. Okay, so factitious disorders are factitious. They're made up. The two different branches of this type of disorder are Munchausen's syndrome and Munchausen syndrome by proxy. So Munchausen syndrome is when you make yourself sick or you pretend to be sick in exchange for attention or sympathy. So you're doing it to yourself. One example that I remember very vividly is a woman who was in the hospital and she had like blood poisoning and all of this bacteria in her blood, and the doctors couldn't figure out what was sending her into septic shock until they found out that she was injecting her IV with her own feces. Well, that's one way to mess up your blood. Yeah, it makes you feel very, very icky. And so they discovered that that's what was causing her illness, that she was doing it to herself, and that's Munchausen's syndrome. Now, Munchausen syndrome by proxy is when you make someone else sick to get attention or sympathy for yourself. So this is typically done by somebody who is a caregiver or a caretaker or a parent, and they want to get sympathy or attention because of how much they're sacrificing for this person who's sick, whether it's their spouse or their child or a foster child. Like Eminem, his mother had him in and out of hospitals his entire childhood because she suffered from Munchausen's by proxy syndrome. So she would constantly take him to the doctors and make him even believe that he was sick and there was something wrong with him so that she could get attention and medications. This can include, like there's a video that I've posted in the Schoology lecture page, hospitals catching parents smothering their own babies in order to gain attention and garner sympathy. Like not smothering them enough to kill them, but smothering them enough to say, oh no, they stopped breathing, and have everybody rush in and do all this attention and this sympathy. There was a very famous example with Gypsy Rose, where she allegedly had cancer, but in reality, her mother was just making her sick and making her think she had cancer. And so she ended up, well, spoilers, I won't let you know. She and her mom did not get along very well. But that's Munchausen's by proxy. It's not a real disease. It's inflicted for sympathy or attention. So that finishes factitious disorders. Now we're going to move into dissociative disorders. So y'all may have heard of dissociation. This is the phenomenon when your mind separates from your body. Oftentimes it's going to occur in traumatic experiences where your brain can't mentally cope with the scenario that's going on. And so it can lead to this out-of-body experience, like you're floating above your body and you're watching these things happen, but you don't recognize that they're happening to yourself. So you're like outside of yourself. It's not really happening to you. And some people with depression or PTSD do experience minor dissociation throughout the day where they feel completely detached from their emotions or from their reality, and they can just like stare off into space and not follow a conversation. But extreme dissociation has some pretty clear symptoms. A person's memories or emotions can be split off from conscious awareness. Now, the most controversial version of this is dissociative identity disorder. It's formerly known as multiple personality disorder. And this is very, very controversial because there's some people who say, yes, there is evidence DID is real. And there are some people who say, no, it's just another factitious disorder where they're making up personalities and doing it for attention. So some of the signs that are in support of DID include different personalities not being aware of each other, different personalities having different handwriting, using different hands to write, having medical disorders like one needing glasses and the other not needing glasses, or one being diabetic and the other not being diabetic. So all of these differences that would be so complicated to keep track as just one person, but it's almost as if it's one body, but there's multiple people living within that one body. But that's the most extreme form of the dissociative disorders. There are some less extreme forms that we're going to get into. Okay, so the first disorder we're going to cover is dissociative amnesia. This is selective memory loss. So y'all may remember
retrograde and anterior grade amnesia,
where they either forget everything from before the trauma, like an accident, or they aren't able to form new memories after the trauma. But it's very, very solid. It's like, okay, here's the point, and it's either everything before or everything after. With dissociative amnesia, it's selective memory loss. You don't forget everything, you just forget parts of something. It's not from a brain injury or a concussion, it's from a traumatic event. So for instance, a woman who gives birth to a stillborn baby may be so traumatized by that loss that she completely erases her memories of ever being pregnant. That doesn't mean she forgets who her husband is or she forgets where she lives. It's just selectively memories that are related to that traumatic event. And that amnesia can last a very long time, or it can disappear just as abruptly as it appeared. But it's not something that's often going to reoccur. It's more so you have one episode of dissociative amnesia, and then you don't go through that again. So this is in response to a trauma, not a physical trauma like a brain injury, like a lesion, but more of an emotional, psychological trauma. A more extreme version of this is dissociative amnesia with fugue. Now, a dissociative amnesia with fugue is where they forget their entire identity. So it's like complete amnesia. They don't remember their name. They don't know who they are. They don't know where they live. They don't know anything about themselves. But they go on and start a new life. So just imagine you woke up in the middle of a Walmart. No idea who you are. No idea what city you're in. But you just walk around until you figure stuff out. And you start buying things or get a job or start a family. You have a completely different life. Now, that amnesia could end and your memory can reoccur. And then you realize, oh, for the last 28 years, I'd been living in Montgomery and teaching, but now in my new life, I was a marine biologist or something completely weird and different. So that fugue could end and you recover your memories and you return to the previous life, or it could continue indefinitely or occur repeatedly over time. So it's not like, oh, you have one fugue episode and then you're done forever. Sometimes those fugue episodes will happen again and again. And in the lecture unit on Schoology, I actually have a video of a professor who went through a dissociative fugue, who woke up not knowing what languages he spoke, not knowing anything about himself, and even being shown pictures of him as a younger man and having no idea who that person was or who the other people in those pictures were. So it's not caused by a lesion in your brain. Some major event, some trigger happens, and you completely forget who you are. Now, dissociative identity disorder is also in response to trauma. Most often, it's a response to childhood trauma, often extreme violence or abuse. And what happens is that your mind literally splits. It breaks into or splinters into different parts. And these parts, these personalities that develop, serve a purpose. The most common personality that emerges with dissociative identity disorder is the protector personality. So if you're going through an extremely abusive or extremely traumatic, violent event, you feel like you can't defend yourself because you're a child, oftentimes a strong, fierce fighter personality will emerge. And then every time you're triggered with a fight or flight response, that personality comes out and takes over and plays the protector role. And so personalities emerge in response to the environment to handle that environment. But when this happens, it can split off communication to those other personalities or those other parts in your mind. So some personalities are aware of others. Some personalities aren't aware of the others. Sometimes they can communicate with each other. Sometimes they don't communicate. It's uncontrollable which personality is in charge at which time. But there are certain triggers that can allow one personality to take over, like the protective personality, in order to get through a stressful situation. Even though there's a lot of controversy about this diagnosis, it is still recognized in the DSM-5. So this is still a legitimate diagnosis. It's just renamed from multiple personalities to DID. So one of the interesting parts about DID is the fact that it involves a lot of the unconscious mind, and that's because it involves repression. Remember, repression and suppression are two different things. Repression is unconscious pushing away of a memory. You don't remember the repressed memory. You aren't aware that you tried to get rid of it or that your brain got rid of it. It's just gone. Suppression is when you're aware of the memory, you're aware of the event, but you try to avoid it. You try to push it away. So DID isn't the result of you go through a trauma and you remember it and you try to forget it, because that would be conscious. DID is a result of unconscious coping mechanisms. Your brain splintering apart to protect your main personality from those memories by putting those memories instead with your alter personalities. And so often the traumatic event that triggers this sort of disorder is an abusive event during childhood, when the brain is still forming, where it's able to split off into those parts. So now let's do a little bit of review about OCD. Y'all may remember that the O stands for obsession, which is a recurrent thought. The C stands for compulsion, which is a recurrent behavior. Now, when we think about OCD, more often than not, in media, it's going to be portrayed as symmetry, order, or exactness. The idea that someone is OCD means that they like things a certain way, or they like things to be straightened or ordered in a certain particular fashion. Even though that's how the media likes to portray OCD, or how we are most likely to recognize it, that's not the majority symptom of most people with OCD. Only 17% report an obsession with symmetry or order or exactness. More, like 40%, report an overwhelming repetitive thought concerned with germs and germophobia. Or 24%, something terrible happening if they don't complete their rituals. You may have some media portrayal overemphasizing certain symptoms, like symmetry and order, and underemphasizing germophobia, which is a much wider reported symptom in this particular disorder. In terms of compulsions or repetitive behaviors, this makes sense that the majority thought or behavior for OCD is germophobia. Therefore, the majority of people with OCD engage in excessive cleaning or grooming habits because of that obsession or phobia of germs. Repeating rituals of going in or out a door or flicking on or off lights a certain number of times. That's also a majority of people with OCD. Checking locks or doors or homework or the car brake. That's also a large percentage, but not a majority of people with OCD. Okay, so there are many different ways that these disorders can manifest, and there's also many different ways in which they can be treated. Remember, the DSM-5 doesn't say the only way to treat OCD is with medicine, or the only way to treat OCD is with cognitive behavioral therapy. It leaves it open-ended. It says, here are the symptoms, here's the prognosis, but there's multiple areas where you could go to for treatment.